Okay guys, Timmy coming at you here, and today in this video what I want to explain is Addison's disease. Now, the most famous guy to have Addison's disease was our former president, John F. Kennedy. And now remember, if you understand what a hormone does, then you'll know what will happen if you have too much of it or not enough of it. So Addison's disease is really defined now as adrenal insufficiency. And it's essentially the lack of three hormones of the adrenal cortex. And we know what those are, right? They are cortisol. And in your book, or you'll learn about the fact that they're called, cortisol is called a glucocorticoid. So it is a steroid hormone that affects metabolism. And specifically, it's designed to raise your blood sugar during chronic stress and recovering from stress. The other one is aldosterone. And aldosterone is a hormone that affects your blood pressure. And what aldosterone does is it affects the kidneys. So if you look here, you remember the nephron, right, from A and P. And what I'm going to do is I'm going to take a cross section of the distal convoluted tubule. So I'm going to take a section here of a section of the distal convoluted tubule and then the peritubular capillaries. So there's a network of capillaries parallel the collecting tubules. And stuff from the blood will be excreted ultimately into the urine, or stuff from the urine will get reabsorbed back into the blood. So I'm going to make a big picture of that and show you what aldosterone does. So here's the peritubular capillaries, and then you have the distal convoluted tubules, the collecting tubules. So the function of aldosterone is to stimulate the sodium-potassium pump in the cells that make up the lining of the distal convoluted tubules. So when aldosterone's around, it's going to cause 3 sodiums to be pumped back into the blood and 2 potassiums to be pumped into what soon will be urine. And the osmotic effect of sodium getting pumped back in the blood is going to reabsorb water back into the blood. So aldosterone increases your blood volume. And anytime you increase your blood volume, you increase your blood pressure. So one of the functions of aldosterone is to raise your blood pressure. All right. Now, the other hormone is DHEA, and this is referred to as the mother of all hormones. So in its function, it is converted to either estrogen in women or testosterone in men. Now, the testes are the primary producer of testosterone. However, the adrenal cortex will kind of make up for that. So in people with Addison's disease, they lack cortisol, aldosterone, and DHEA. Now, if you look at Kennedy when he was young, he was skinny, right? And they show pictures of him. He always had a bad back, chronic back pain, leg pain, hip pain. And the other function of cortisol is to function as an anti-inflammatory. So if you don't have cortisol, then you basically have no natural anti-inflammatory. So anytime you injure tissue, you're going to get inflammation, and it's going to produce pain. So let me explain a few things, and then I'm going to get into Addison's. Now, as we know, the hypothalamus and the pituitary gland are intimately linked. So the hypothalamus under chronic stress is going to release cortisol releasing hormone. So the hypothalamus will stimulate the anterior pituitary, and the anterior pituitary is then going to release ACTH. ACTH stands for adrenal corticotropic hormone. Tropic means to increase or develop. And the adrenal cortex is ACTH's primary target. So it's going to stimulate the cells of the adrenal cortex to release cortisol, aldosterone, and DHEA. Primarily cortisol. Now, we know cortisol's functions because you had to learn that in order to understand Cushing's disease. So again, cortisol's primary function, or one of its functions, is as an anti-inflammatory. So basically it suppresses the immune system, and the immune system protects you. So people with Addison's, one, they're not going to get the anti-inflammatory effect, right? And their immune system is going to be hypersensitive. And it also participates in gluconeogenesis. Now, that's a fancy way of saying that you take typically amino acids, and amino acids build protein. So basically what cortisol does is it will break down the protein, specifically collagen. It's very sensitive to collagen. And it will take those amino acids that make up that collagen, bring it to the liver, and convert it to glucose. And that will raise your blood sugar. And that's the protein mobilization effect too, right? Protein mobilization, breaking down the protein in collagen and then converting it to glucose in the liver. It also mobilizes fat too, and what that means is there's basically fat redistribution with the effects of cortisol, and it tends to deposit fat in the face, in the belly, and in the back. So people with a lot of cortisol are going to get that buffalo hump. Now, with lack of cortisol, you're not going to be able to store fat as easily, and that's one of the reasons he was skinny. Now, you're also not going to have the effects of aldosterone, and aldosterone affects the renal tubules, as I explained to you, by stimulating that sodium-potassium pump. So if we look with the effects of the kidney, remember, aldosterone stimulates the sodium-potassium pump. So it's going to put sodium into the blood and water with it, and it's also going to excrete potassium. So if you don't have aldosterone, as people with Addison's disease, they do not have aldosterone, not a lot of it. What they're going to do is they're going to be peeing out a lot of sodium, and the water is going to follow it. So they're going to have low blood volume. And if you have low blood volume, then you're going to have low blood pressure. Also, because they're peeing out all that sodium, they're going to have low sodium. And that's one of the ways you diagnose it. Now, the only way to get potassium out of the blood is to pump it out, and you pump it out with the sodium-potassium pump, and aldosterone stimulates that. So without aldosterone, as is seen in people with Addison's disease, the blood levels of potassium go up because the potassium is not getting pumped into the urine. Excuse me. And that elevated potassium can cause your heart rate to slow. So they complain of fatigue, and they also get what's called postural hypotension. So if they're laying down, they're okay, then they stand up, and due to that lack of blood volume and the slow heart rate, they pass out. So what causes Addison's disease? Again, the cause is usually autoimmune. So you have antibodies that affect the cells of the adrenal cortex. Sometimes it'll affect the entire adrenal gland, destroy it. So now you lack epinephrine as well. We know what the effects of epinephrine are. So that is Addison's disease. Now, let's go over the signs and symptoms of Addison's. And then, again, if you understand these things, again, if you know what the hormones do, then you'll know what will happen. Now, remember, they lack cortisol. So one of the functions of cortisol is to raise your blood sugar. So they will be hypoglycemic. That's why Kennedy would always carry candy in his pocket, because if he felt hypoglycemic, he'd eat some candy. They're going to complain of joint pain, right? And pain in general, because cortisol is the body's primary anti-inflammatory. And they'll develop constipation. Constipation can lead to nausea. If you don't digest your food or it's backing up, then you'll get nauseated and sometimes vomit. And the hypovolemia really contributes to that. And basically what's happening is you're making your poop so dry that it becomes constipated. Then they have elevated potassium due to the low aldosterone, and that's important. Elevated potassium affects the heart by basically slowing it down and making the contractions weaker. That also contributes to the low blood pressure. And then again, the low blood pressure due to the hypovolemia and the no aldosterone. And in men, low testosterone, because DHA is converted to testosterone in men and to estrogen in women. And they also have a salt craving as well. One more thing is they tend to get this kind of like the only way I can explain it is a goofy tan. Let me explain that. ACTH and melanocyte stimulating hormone. Melanocyte stimulating hormone stimulates the pineal gland to release melanin. It also stimulates melanocytes in the skin to produce a tan. Now, the precursor hormone for ACTH and melanocyte stimulating hormone are very, very close. Very, very close. And as a result, ACTH, some of that hormone will not be converted to ACTH, but rather some of it will be converted to melanocyte stimulating hormone and will stimulate melanocytes, and they'll get that kind of goofy tan. And that's present in almost all people with adrenal insufficiency. Now, those are some of the signs and symptoms, right? So what do you do for these people? Well, first of all, to diagnose it, you're going to look at the history, obviously, and then you're going to look at labs. And what you're going to find in terms of the labs is you're going to find a low blood sugar. You're going to find low sodium. You're going to find an elevated potassium. And depending on whether it's primary or secondary Addison's, and I'll get to that, regardless, you're going to have low cortisol levels, low aldosterone levels, and low DHEA levels. These are the two hormones that are typically measured. Now, when you talk about the difference between primary and secondary Addisons, all right, let's break that down a little bit. All right, so in primary, it's an adrenal problem. Right? In secondary, secondary, it's a pituitary problem. All right, so primary adrenal problem, secondary pituitary problem. So to diagnose this, what they do is they will do what's called a dexamethasone challenge. Dexamethasone is similar to ACTH, or they'll give ACTH. I spell challenge, two ends in challenge. That don't look right. Well, you know what that is. Dexamethasone challenge. So now dexamethasone is similar to ACTH, the hormone that stimulates the adrenal cortex to release cortisol, DHEA, and aldosterone. Now, if you give them dexamethasone and you draw their cortisol level, so if you give them dexamethasone and then you draw their cortisol level and their cortisol level rises, then you know that it's secondary, meaning the pituitary gland is not releasing ACTH like it should. Now, if you give them the dexamethasone challenge and the cortisol levels do not rise, then you know it's an adrenal problem. So, based on whether it's primary or secondary, that will determine the type of treatment. Okay, so the treatment of Addison's disease is basically the replacement of the hormone cortisol. And they use prednisone, usually 10 milligrams per day or less. And prednisone is a byproduct of the metabolism of prednisone in the liver. So prednisone is usually given for long-term use to prevent liver damage. Now, so let me backtrack here a little bit. So again, we talked about the two types of Addison's: primary, where it's an adrenal problem, and secondary, where it's a pituitary problem. Now, again, if it's a primary problem with the adrenal gland and the pituitary is fine, then if you draw an ACTH level and it's elevated, and then the cortisol level is low, the pituitary gland is doing its thing, right? If the adrenal gland was releasing cortisol, then it would feed back on the pituitary to say, stop releasing ACTH. But if the adrenal gland is the problem and it's not releasing cortisol, then the pituitary is going to do its thing and say, hey, buddy, come on, release some cortisol, release some cortisol. So in primary, the ACTH will be elevated and the cortisol will be low or non-existent. Now, in secondary, where it's a pituitary problem, you're going to have low ACTH and low cortisol. So in order to get cortisol released from the adrenal cortex, there has to be a signal. What's the signal? ACTH. But if the pituitary is causing the problem and not releasing ACTH, then you know it's a pituitary problem. Now, in many cases, it's a tumor of the pituitary. And tumors of the pituitary can result in one of two things. It can result in increased release of those particular hormones or no release at all. So in secondary, if it's a pituitary problem, then you have to find out, well, what's causing the pituitary problem? Is there a tumor? What's going on? But ultimately, the treatment for it is going to be hormone replacement. So if you look here, young Kennedy and then older Kennedy, if you look, his face kind of got more round, and he kind of had that tan too. Again, everyone thought he was tan because he was at his place in where is it, Massachusetts, Kennebunkport, and he was out in the sun. Well, that may have contributed to it, but the fact is that he had Addison's, and he was being treated for it as a result. But regardless, he was still in chronic pain. So again, and let me say this one more time. If you know what a hormone does and you have too much of it, you know what will happen. You will also know what will happen if you don't have enough of it. So if you don't have enough of it, you find out why, you treat the cause. In the case of primary, you give them cortisol. Prednisone or prednisone is a corticosteroid that it's synthetic, and it's very, very similar to cortisol itself. So that's the primary treatment. All right, and I hope that helped a little bit.